Welcome to the webinar tonight. First, we will introduce the THQA President, 中华民国重症医学会理事长。我们邀请那个黄瑞仁院长来致辞。黄院长，请。
好，各位线上台湾的医师们，还有来自美国的 Dr. Tina Chen， 那另外还有郭怡、Pharm.D and Tara。那今天非常高兴 ，Tina Chen 在非常短的时间内受邀 organize 今天这一个短1个小时的 symposium。那目前台湾 Omicron 正在 emerging， 所以到底我们对付 Omicron 的这个 policy 是要怎么样？那当然，因为它的传染力很强 ，R0 几乎是10左右，那所以我们必须应该是要放轻的救重的。应该是这样的 policy， 所以我们希望学习美国的经验。那另外对整个保存医疗量能，我们要如何来处理？那也希望 Tina Chen 还有相关的这些 faculty 都可以给我们一些经验。那其他的相关的 那另外，我们当然很希望台湾可以借重美国的经验来对付这一波的 Omicron 的疫情。所以 it is my great pleasure. I'm Dr. Chen Huang from National Taiwan University Hospital. I'm currently is president of Taiwan Society of Critical Care Medicine. I should give my Chen to organize this symposium and to share with the experience of the Omicron of COVID-19, how to combat the emerging COVID-19 pandemic to Taiwan. I am very glad to thanks to all the speakers tonight and hope we can learn some experience from the United States. Thank you to all.
非常感谢黄瑞仁理事长的支持哦。那接下来我们邀请高雄荣民总医院陈金顺副院长，高雄 Veteran General Hospital Deputy Superintendent Dr. Chen。Dr. Chen, please.
OK， 好，谢谢那个维森理事长哦。我们从这个来自美国的一个3位的一个专家哦，以及所有我们台湾各地的一个线上的伙伴们哦，大家晚安，大家好。那我是高雄荣总的副院长陈金顺哦。那如同大家都知道的哦，那今天晚上主要都是我们来自台湾的观众哦，所以就用中文跟大家做一个简单的一个开场。那大家都知道，我们新冠的疫情已经进入到第3年了。那目前全球疫情的一个情况的话，我们的病毒的一个变化从 Delta 现在变成到 Omicron 哦，那它目前是突变最多的一个新冠病毒的变体哈。那根据 WHO， 我们已经几乎把那个 Omicron 的话列为我们很关切的一个变异株哈。那它的特点就是如同刚刚黄理事长讲的这个。它的传播的情况是非常的多而且快速的哈，但是整体而言，它的症状是比较轻啊，那导致它的住院跟死亡的病例是比较少，跟之前的一个变异株来比较，上面是比较少的哈。那现在目前会有这种情况的话，当然跟我们现在全球的疫苗的接种啊，还有我们自然的免疫产生的抗体，各种的因素都有它的一个相关性哈。那如何学习跟后续跟这些病毒共存的话，这是台湾目前最重要的议题哈。那今天晚上很高兴，我们高雄荣总就是持续我们在优化我们的新冠病人的一个照顾哈。那这次跟台湾品质医疗学会，还有我们重症医学会，还有台湾心肌梗塞学会，我们就合作了今天晚上的一个视讯课程哦。那希望在这个关键的时刻哦，我们可以一起学习美国经验来守护我们台湾哈。今天很感谢3位从美国来的一个专家跟我们分享他重要的一个防疫经验哦。那祝今天晚上的这个会议大家都收获满满哦，大家都平安喜乐。谢谢大家，谢谢。
感谢陈副院长。那接下来我们邀请到我们的台湾医疗品质协会的理事长 THQA President Dr.郑教授来做致辞。教授请。
这个主持人以及3位美国的 distinguished special guest 的 speaker good morning 应该是 good night 啊。那还有我们的台湾的这种医界的好朋友们，大家好啊。我想这一次是台湾是一个重要时刻哈。那 today April 21st the Central Epidemic Command Center announced Taiwan 358 new confirmed cases of COVID-19 啊，这已经是突然一天超过3058个啊，所以呢pandemic 的 is very severe， 所以今天的一个这个会议呢对我们台湾来讲是一个非常重要的，尤其台湾面临的几波的一个疫情的努力。从清零的要求一直到最后已经要与病毒共存，开始有很多的居家送药或怎么样。我相信这个 the experience of the United States is very important to us to us。我相信今天会给我们很多的一些 一些想法。那我祝今天线上的好朋友们面对这疫情呢3位美国来的好朋友呢这个专家应该会给我们很多的一个指导。我这边祝福大家，希望大家收获满满，也希望大家共同很快的来面对来让我们的这个生活能够恢复到正常。好，谢谢大家。
Since the President Chen, I'm Wei Chong Huang. Today we 请注意事项就是如果有问题的话，请用 Slido 的平台来去问问题，我们会提供协助来问问题哈。那今天也非常感谢重症医学会跟医疗品质学会TAMIS 高雄荣总一起来举办这活动哈。Later on we will introduce our disclaimer speaker from the New York, Dr. Tina Chen, and he is an expert in critical care in Montefiore Medical Center. And also, we also invite Dr. Yi Guo, she's Pharm.D, also from the Montefiore Medical Center. He is the chair of the infectious clinical pharmacy. And also, we have a disclaimer speaker from the UCLA. Is an infection expert, Dr. Tara Vijaya, and he will introduce some of the COVID-19 virus experience. We also invite some of Taiwan experts, including from Taiwan University Hospital, Dr. Tony Ye, and also from the National Taiwan University, Dr. Wei-Tin Zhang, and also Dr. Yi Guo, also from the Taiwan University Hospital, and also the Dr. Guangyao Yang from the Taipei Veterinary General Hospital, and the Dr. Susan Xinong Li from Kaohsiung Veterinary General Hospital. He's the expert in the infectious disease, and also General Secretary of the THQA, Dr. Wang Chuan-Zhen from the Kaohsiung Veterinary General Hospital. So today we will focus some more topic about virus, critical care, medication, and vaccine. So let's hand out the time for the Dr. Tara first. Tara, please.
Thank you so much. It's really my pleasure to be here. I'm going to share my slides here. Somehow I'm not able to do this immediately, but let me see. Hold on. Okay, here we go. Okay, can you see my screen?
Not yet.
Not yet, huh? It says they can't display my shared content because I don't have permission.
Permission? 小小，他说他没有
send
得
the
到授
slide
权。
to me and let me see if I could do it from this side.
I sent it to you, Tina. I actually
Oh,
sent it to
it's
you,
the same one from, okay.
From this morning.
From this morning? Okay. Let's see. From this morning?
Mm-hmm. Yeah, I'm trying different ways, but it's not letting me.
I have one from last night.
That's Yi's.
That's Yi's, okay.
Let's see. I don't know if Yi wants to try first. Oh, actually, you know what? I had only sent it to Yi. Hold on one second. Let me send it to you.
Just send it to me and then I'll play it from, because I have WebEx installed, so hopefully that'll let me share.
Okay. Can you just remind me? Oh, here.
大家晚安。You just sent it?
Mm-hmm.
Okay, let's just wait for a second. Got it.
Okay.
Good.
Can you guys see the screen now? Okay.
Okay.
Yeah, no
Yes,
problem.
we can
Thank you.
see.
Please.
Yep. So Tara, just let me know when to advance, okay?
Okay, okay, thanks so much. Okay, you can advance actually. Thank you so much for inviting me. I just wanted to talk a little bit about how we've been approaching therapeutics, so treatment for COVID-19, both in the outpatient setting and in the inpatient setting, and really using the evidence that we have available. So one thing I want to highlight is when we are looking at the evidence, when we're looking at studies, the outcome may be different from study to study. But in general, there are some principles that we can see. When we're looking at studies that look at inpatient treatments, there are specific outcomes that we look at, including the NIH ordinal scale, which basically tracks a patient from the ability to discharge the patient outside of the hospital to mechanical ventilation and death. And then we also look at for outpatient treatment, we look at actually progression to hospitalization. So our goal is actually to prevent hospitalization in the outpatient setting. It is not to reduce symptoms. It is not to prevent long COVID. And it is not to decrease the viral load because we don't have those data. Most of our data is really looking at prevention of hospitalization. And when we're comparing different treatments, as long as the efficacy is similar and the primary outcome is the same, then we can assume that there is some clinical equipoise, and that means that the drugs that we are looking at may be similar, and you can potentially replace one with the other. Next slide, please. So this is an overview of our treatment approach, and I'm just highlighting here the different targets of our therapies. So in the first half, we're really looking at outpatient treatments, and the way that we target our outpatient treatments is really by doing two things. One is targeting the ability of the virus to enter the cell, and that is through monoclonal antibodies, as well as something called convalescent plasma, which is basically antibodies that are harvested from donors, from blood donors. The monoclonal antibodies that we have available to date are bebtelovimab, which is the only one that works against BA.2 at the moment. The other monoclonal antibodies that we've had over the last year no longer work against the current variants of concern in the United States. And then we have one new monoclonal antibody that is primarily has been created to prevent COVID-19, and that's tixagevimab-silgavimab by AstraZeneca. And that monoclonal antibody is meant to be a supplement to the vaccination in patients who are likely to poorly respond to vaccination. So those are our patients who are profoundly immunosuppressed. Then we have our medications that target the reproduction of the virus. So they do that by a number of different ways. They either target the actual genome, the RNA, by inducing mutagenesis. That is called molnupiravir. It actually induces mutations in the coding, and that was produced by Merck. And then we have Paxlovid, which is a protease inhibitor, which for those of you who are familiar with treating patients with HIV, contains actually a medication that we use in HIV called ritonavir. And then remdesivir, we use here in the United States quite freely, both in the inpatient setting and in the outpatient setting. And I will share with you the most compelling data is really in the outpatient setting. It is FDA approved here in the United States, and that actually targets RNA-dependent RNA polymerase. And then lastly, we have, for those who are hospitalized, by the time they are hospitalized, they are typically hypoxic. Their oxygen levels are very low, although we do have a number of patients who are admitted with COVID-19 who are not necessarily hypoxic, but they've been admitted for other reasons. For example, if they have a hip fracture and they happen to have COVID-19 and they may have mild symptoms. But most of our patients who are admitted with COVID-19 generally have low oxygen levels. And those patients, we think that the viral replication is less of a problem. It is really the overwhelming immune response. And the way that we target that is with steroids, notably dexamethasone, IL-6 receptor blockers such as tocilizumab and cerulumab, and JAK stat inhibitors such as baricitinib, tofacitinib. Next slide, please. So this is our approach in the inpatient setting. So when patients are hospitalized, we only treat patients who have symptoms. Now, there may be some exceptions to this, and the exceptions to that would be patients who have recently had an organ transplant, patients who actually have had a stem cell transplant. There may be some case-by-case scenarios where we treat those patients, even if they're not symptomatic. But by and large, the patients that we focus on must have some symptoms. And then we basically divide it into whether they have hypoxia or whether they don't have hypoxia. And so if they are not hypoxic, but they have symptoms, and their symptoms are fewer than 7 days, then we give them remdesivir for 3 days, especially if they are high risk. And I will share with you the data that support this decision. If they are hypoxic, if their oxygen saturation is less than 94%, the threshold is quite low, or quite high, I should say, for our population. And if they have symptoms fewer than 10 days, then we give them remdesivir and dexamethasone. If they progress to high flow nasal cannula, we actually consider baricitinib. And then if they are mechanically ventilated for fewer than 24 hours, we will give them tocilizumab. And I will show you some of the data in support of these drugs. And then if they're hypoxic and their symptoms are more than 10 days, then we actually don't give them antivirals because we don't think that viral replication is a big part of their process unless they are profoundly immunosuppressed. But if they are not immunosuppressed, then we defer the antivirals. We don't give them remdesivir. And we only focus on the immunomodulators, dexamethasone, baricitinib, if on high flow nasal cannula, and tocilizumab if mechanically ventilated. Next slide, please. So these are the data that support remdesivir for 3 days. This was the Pine Tree study that was published in the New England Journal of Medicine on December 22nd. And you will note that 584 patients were randomized within 7 days of symptom onset. They were only considered high risk. So the high risk included individuals over the age of 60, individuals with a high body mass index, so our obese patients, individuals with hypertension, diabetes, and those who were immunocompromised. And all of them were not vaccinated. So they were high risk by virtue of not being vaccinated as well. A small fraction came from a population that in the skilled nursing facility. So they weren't in the hospital. All of these patients were not in the hospital, but a smaller percentage came from what we would call our rehabilitation facilities, our skilled nursing facilities. And the primary outcome, which was prevention of COVID-related hospitalization or death, was reduced by 87%. So there was a marked reduction in hospitalization for this population. There was also a reduction in death from any cause. Next slide, please. So I want to, for the inpatient, so the remdesivir we use in the inpatient setting for 3 days if you are don't have hypoxia, and then for 5 days if you do have hypoxia. Steroids are exclusively used for individuals who are actually hypoxic. And this was based on the recovery study. And I'm highlighting here a couple of things. If you look at panel D here, these are the patients that did not receive any oxygen. And in this population, the use of steroids resulted in a slightly higher risk of death. So for patients who are not hypoxic, we do not give steroids. But for all other patients who were hypoxic, there was a total of almost 20% reduction in mortality. And then that was more significant among those who were mechanically ventilated, nearly 40% reduction in mortality, or 36%. Next slide, please. So other immunomodulators I'm talking about here. There have been a lot of mixed data with these different medications, but ultimately the way they worked the best was if they were given with steroids. So I'm highlighting here baricitinib in the Cove Barrier study showed a 48% reduction in mortality among those on high flow nasal cannula or non-invasive positive pressure ventilation. For tofacitinib in the Stop COVID study, the reduction was 37% in mortality. And again, most of these patients were on steroids. For tocilizumab, there were a number of studies that initially did not show any benefit, but when we looked at the studies that had patients mostly on steroids, such as the recovery study and the REMAP-CAP study, there was in fact a mortality benefit in both of those studies for tocilizumab. And then similarly for cerulumab, for the REMAP-CAP study, there was a benefit. So I'll show you actually the REMAP-CAP study. Next slide, please. Where this clearly shows the probability of survival, and the purple line is actually cerulumab, the blue line is tocilizumab, and the red line is the control arm. And you could see there's a survival benefit for both cerulumab and tocilizumab. When they look at probability of discharge from the ICU, that's panel C. Again, the purple line is cerulumab, the blue line is tocilizumab, and there was a higher probability of discharge from the ICU if these patients were given this drug. Now, timing is everything. We really, the benefit is really within the first 24 hours of mechanical ventilation, and to a lesser extent, if they're on non-invasive positive pressure ventilation. So those are the populations that we focus on. Next slide, please. I will note a little bit about anticoagulation. Our National Institute of Health treatment guidance was updated in January of this year after a number of studies actually suggested that there was a benefit specifically in patients who were on low flow oxygen and had an elevated D dimer. And in this population, we consider therapeutic enoxaparin rather than prophylactic enoxaparin. So for us, that's actually twice a day enoxaparin. I will say everybody should get prophylactic enoxaparin regardless. But if patients have low flow oxygen and have an elevated D dimer, they can actually be considered to get therapeutic anticoagulation unless there are contraindications. Now, interestingly, in the population that was mechanically ventilated or on high flow nasal cannula, there wasn't any benefit in giving therapeutic anticoagulation. So if patients progress to become mechanically ventilated, if they require to be intubated, the recommendation is actually to put them back on prophylactic anticoagulation, not on therapeutic anticoagulation. Next slide, please. So this is our outpatient approach, and it has become much more simplified. In general, overwhelmingly, we only treat patients who are symptomatic. If they have symptoms fewer than 5 days, then we consider the protease inhibitor, nirmatrelvir ritonavir, also known as Paxlovid. But if they have many drug interactions, which some of our patients do, and Dr. Guo is going to talk a little bit about that, we only consider monoclonal antibodies or remdesivir. If their symptom onset is between 6 and 7 days, then we consider monoclonal antibodies or remdesivir. Next slide, please. So the nirmatrelvir ritonavir data was published in February of this year. They looked at 2,200 patients, and they found an 89% reduction in hospitalizations or deaths. The main thing that, the main barrier to giving Paxlovid is actually drug interactions. And the ones that we focus on are anticoagulation, antiarrhythmics, antipsychotics, and also our transplant medications. And I've highlighted here a website that you can use to look at drug interactions. And then lastly, there is different dosing for depending on creatinine clearance. Next slide, please. The MOVE-OUT study actually looked at molnupiravir, and that actually is another drug that showed much more modest benefit. It was published actually also in February, and it showed a 30% reduction in hospitalizations and deaths. So that's very different than the 87% reduction in hospitalizations or death that we've seen with the other studies. So things to note are it can be teratogenic. It should not be given to pregnant women. And it should also, females of childbearing potential should use a reliable method of contraception. Similarly, males of reproductive potential who are sexually active with females of childbearing potential should use a reliable method of contraception during treatment and for at least 3 months after the last dose. Next slide, please. Excuse me for 1 second, I apologize. So I just wanted to highlight here, these are monoclonal antibodies, and I assure you I don't have COVID, I just have allergies, I apologize. But these are monoclonal antibodies are one of the main outpatient treatments that we've used in the last year. The way they exert their effect is by targeting the receptor binding domain of the spike protein, and they essentially prevent entry into cells. They also will they will actually target infected cells by increasing macrophage consumption. And so you can see here the benefit of the monoclonal antibodies and convalescent plasma, both of which work in the same way. This is a nice preprint that was published recently. And you can see that the efficacy is best in the pre-exposure and early symptomatic phase. It is not really beneficial among those who are hospitalized or who are mechanically ventilated. Now, the exception to this may be in those patients who are profoundly immunocompromised, who cannot mount an antibody. So among seronegative patients, if they have a negative anti-spike antibody, there may be some benefit to giving these drugs to patients later in their hospitalization, but the true benefit is before hospitalization. Next slide, please. And so I'm just going to highlight here the variance and effectiveness of monoclonals have changed over time. In California, actually, we had a variant known as the Epsilon variant that rendered the first monoclonal bamlanivimab ineffective. Since then, since the Omicron surge, casirivimab and imdevimab has been rendered ineffective. And then most recently, sotrovimab has been rendered ineffective against Omicron, the BA.2 variant. Next slide, please. I'm not going to belabor this, but these are some of our own internal data. And, you know, the early data showed a significant reduction in hospitalization and death. And we looked at our own data, and we saw the greatest reduction was actually among those who were unvaccinated. So there was a 61% reduction among those who were unvaccinated. Next slide, please. So in summary, these are the different treatment options. There's monoclonal antibodies, sotrovimab and bebtelovimab. Sotrovimab we are now no longer using. They should be used within 7 days of symptom onset, and there's an 85% reduction. For sotrovimab, again, we don't use sotrovimab for BA.2. There are currently no clinical data available for bebtelovimab yet. Paxlovid, you give within 5 days of symptom onset, and there's an 89% risk reduction. Molnupiravir, you give 5 days within symptom onset, and there's a 30% reduction. So we don't really give molnupiravir because we have the other agents available. And then remdesivir is another regimen that is actually considered second to Paxlovid. Bebtelovimab is actually considered third line because we don't have as much data. But you can give remdesivir, you have to give it for 3 days. So that actually is a little bit of a problem in the outpatient setting, and there is an 87% risk reduction. Next slide, please. So who gets sick from COVID in the vaccine era? Those who remain unvaccinated with high risk factors, those who have not received full vaccination, and those who are likely to not have had an adequate response to vaccination. And this was a nice study published by the CDC that really shows this. The solid line here are the unvaccinated individuals, and you can see the number of cases is very, very high compared to those who are fully vaccinated without the booster and those who are fully vaccinated with the booster. And the gray area here is actually when we had our first Omicron surge. So even in the Omicron surge, those who are vaccinated were far less likely to get infected. Similarly, for deaths, those who are vaccinated are far less likely to die than those who are unvaccinated. And that persisted during the Omicron surge. Next slide, please. So when we're thinking about whom to treat, we didn't at one point we didn't have enough drug to treat everybody, so we really focused on the highest risk individuals. And I'm highlighting here the different tiers. Tier 1 and Tier 2 were the individuals that we focused on the most. Those were generally unvaccinated individuals, as well as immunocompromised individuals not expected to mount an adequate immune response. Next slide, please. These are the different immunosuppressive conditions that we focused on. They include individuals who were on B-cell depleting therapies, including rituximab, those who were on certain Bruton tyrosine kinase inhibitors, such as ibrutinib. This is for things like chronic lymphocytic leukemia, those who had undergone stem cell transplant recently or had graft versus host disease or lung transplant or other solid transplants within a year. And then we also included all transplant patients who have ever had a transplant in Tier 2, as well as those who are on active chemotherapy. Lastly, we also included individuals who have HIV who are untreated with a CD4 count less than 50. Next slide, please. So that brings me to the last topic, which is actually tixagevimab, silgavimab for prevention. The data actually were just published yesterday, so I have not updated the slide. This was actually prior to those data were published, but there was a 77% reduction in infection, and this reduction was maintained for over 6 months. So this is a monoclonal antibody that you give before patients get COVID. So patients should not have COVID, but these are for patients who are in those Tier 1, Tier 2 category who are likely to not respond to vaccination. So we give everybody the vaccine, but in those patients, we also give them tixagevimab, cilgavimab to prevent COVID-19. Next slide, please. We do not give tixagevimab, cilgavimab if patients have not been vaccinated. And that is because we want to make sure that they have as much of a response as possible to the vaccine, so that they're given an opportunity to mount a T cell and B cell response to the vaccine, a polyclonal B cell response. Tixagevimab, cilgavimab actually does work against BA2. It was less effective against BA1. So it is not perfect. And so we really try to counsel our patients that it is not a replacement for the vaccine. The vaccine is actually much better, even if our patients who are immunocompromised are less likely to respond. Next slide, please. So this is my final slide, just as a reminder. Our goals of treatment are to prevent hospitalization among those who are not hospitalized, to prevent progression among those who are hospitalized, to shorten symptoms or prevent long COVID is not a goal. Vaccination remains key to achieving all of the above. The unvaccinated and undervaccinated are prioritized for treatment, but we are not giving them the prevention because it is not a replacement for vaccination. So they need to get the vaccine first. And with that, I will end there. And I'll maybe take questions at the end if needed. Or if people want to ask questions right now, I'm happy to answer.
Tara, thanks so much. Please take care.
Oh, thank you. Thank you.
I worry about your runny nose. So maybe we Dr. Gao, could you have a answer for other question? Dr. Gao? Dr. Gao, please. We cannot hear from you. Dr. Gao, your microphone is shut down. Dr. Gao, sorry, we cannot hear from you.
Hey, we could see your screen, but we can't hear you.
Because your microphone, you should turn on your microphone.
Hey, you're on mute.
Tina, could you give her
I know,
a
I'm waiting for her. I'm not in the same office with her.
What's going on?
E? We can't hear you. Oh, I think she got kicked off, so she's logging back in. Do you want to take questions first then, Tara?
Yeah, sure. I'm happy to take any questions, actually.
Back.
Question for Dr. Vijayan?
How about
I
Dr.
think-
Gu?
She's logging on, so why don't we use this time to answer some questions? Yeah?
I have
I
a
think she's
question
on.
for Tara.
Yes, okay.
Please.
I'm Dr. Susan Lee. Tara, you know Israel began administering a fourth dose of the BNT vaccine to persons 60 years or older with high-risk population and healthcare workers since this January. And they showed that in the elderly, a fourth dose was more effective than 3 doses in lowering the rates of confirmed SARS-CoV-2 infection. However, preliminary data looking specifically at healthcare workers observed a low vaccine efficacy against infection, and in those who were infected, they had relatively high viral loads, suggesting they were infectious. Seeing these only marginal benefits of a fourth dose in a vaccination in healthy young healthcare workers, what are your views on giving a fourth dose vaccination for healthcare workers?
Yeah, thank you for asking that. So, in the United States, actually, the fourth dose was approved for those over the age of 50. And actually, I think Dr. Guo is going to talk a little bit about the data as well. But I personally am not recommending. So the main population we're focusing on the fourth dose for, and actually it's really, in the population that needs the first booster, right? So in the immunosuppressed population where 3 doses were actually part of the original primary series, the fourth dose is actually the first booster. And those are in the patients that are profoundly suppressed. Those are the patients that we're focusing on the most to get that fourth dose. Now, I think that the elderly population, the question is what is defined as elderly? Is it over 80? Is it over 70? Ultimately, I have been counseling my patients over 80 to consider the fourth dose. I think at this time I personally am not pushing for the fourth dose in the vast majority of non-immunocompromised individuals.
Dr. Guo, do you want to take over?
Are you able to hear me okay now?
Oh yeah, great. So nice to hear
Apologize,
you.
somehow I got kicked off, so I have to log back in again. So hi everyone, my name is Yi Guo. I'm the infectious disease pharmacist at Montefiore Medical Center in New York. Tina, will you be able to share the screen?
Is this the same slides that you sent me last night?
Yes.
Okay, I will share those for you.
Because I think I tried to share the screen before and
then that locked
off.
you out?
Yeah.
Yeah, sure, I'll do it. Hold on. Give me 1 second, sorry everyone. Are we seeing the slides now?
Yes.
Yeah, great.
Great. So just want to thank Dr. Huan and Dr. Tina Chen again to inviting me to share my experience of outpatient COVID-19 therapeutics. And Dr. Vijaya just went over the science and clinical trials of COVID-19 treatment. And I'm going to focusing on the treatment experience that we had with oral antivirals and monoclonal antibody for COVID-19 treatment. Next slide. So first, I will review the drug-drug interaction and adverse drug events commonly associated with oral antivirals and monoclonal antibody, and basically what we need to watch out for as a clinician upon starting the treatment and how we manage these drug-drug interaction. And then I will share some of our institutional data on how are the monoclonal antibody and oral antivirals being used during COVID waves. And at the end, we will discuss the data on the fourth dose of COVID-19 vaccine. Next slide. So just a little bit about the background of Montefiore Medical Center, where Dr. Tina Chen and myself work every day. We're a pretty big academic teaching hospital with more than 1,400 beds located in the Bronx, New York. We serve a huge population of underserved community of more than 1.4 million residents, and with 93,000 hospital administration every year. And the hospital has 4 major campuses, including a children's hospital, and we have 9 adult ICU critical care units and also 3 pediatric critical care units. And we have very diverse patient populations, including immunocompromised patients, such as solid organ transplant, bone marrow transplant, and HIV patients. Next slide. Since March 2020, New York City went through 4 COVID-19 waves, and we got hit really bad during the first wave. But as we go through each wave, we learned many lessons on how we manage COVID-19 patients. And this graph represents our current COVID-19 positivity rate at our emergency rooms during the past 2 months. And just look at the past 7 days, we start to see a little increase of positivity rate. And on average, the positivity rate is about 4% right now. And therefore, outpatient treatment for mild to moderate COVID-19 patients is very important, because if we can treat these patients in the community setting, we can prevent or reduce hospital admission and to save the hospital resources for the sickest severe COVID-19 patients. Next slide. So this table summarizes some of the outpatient treatment options that Dr. Vijaya just discussed earlier. So let's take a closer look at each medication and go over some of the pros and cons. So according to the NIH IDSA guidelines, Paxlovid is the first option with the great efficacy data to close to 90%. And it comes in oral forms, so patient can take it at home and there's no need to come to the hospital. So it's safe in pregnancy, but the disadvantages are we need to watch out for drug-drug interaction, since Navtelvir and Ritonavir are both protease inhibitors with lots of cytochrome P450 drug-drug interactions. And I'll go over some of the important drug interactions the next slide. And the Paxlovid is also primarily cleared renally, so it's needed, the renal dose adjustment is needed for patients' creatinine clearance is between 30 to 60. And we need to reduce 1 tablet of Navtelvir, so patient will take 1 tablet with Navtelvir with Ritonavir twice a day. And the FDA just released the new renal dosing package for renal impaired patients to prevent medication error. So since there's no data on creatinine clearance less than 30, so Paxlovid is not recommended for dialysis patient or any patient whose creatinine clearance is less than 30. And if the patient cannot take Paxlovid for whatever reason, then the next option for us is monoclonal antibody. And I listed baptilovimab here, since this is the only monoclonal antibody is active against the Omicron B2 variants. That's what we are using now. And the monoclonal antibody is also highly efficacious and is safe in pregnancy. We treated many patients with monoclonal antibody and Paxlovid for pregnant patients. Another advantage is that it's highly active, very efficacious, and safe in pregnancy, and there's no drug interaction. But the disadvantage is that patient needs to come home or come to the infusion center or a hospital designated location to receive these treatment. And after the treatment, and the patient is required to stay and need to be observed for 1 hour before we can let the patient go home. And if patient cannot take Paxlovid or monoclonal antibodies, then the last option really for us is Molnupiravir. And also, although it comes in oral form and there's no drug interaction, but it's not as efficacious, and also it's not safe during pregnancy. Therefore, it is not recommended for pregnant or lactating women. And as Dr. Vijaya pointed out earlier, for female-male patients of reproductive potential, contraception is needed for female during the treatment and 4 days after treatment, and also for male during the treatment and at least 3 months after the last dose. Next slide. So Paxlovid is our go-to drug if patient meets the criteria of treatment. And this table summarized some of the important drug-drug interaction. So let's start with the easy and common one, which people ask me all the time, because the management is very straightforward. If the patient is on Tamsulosin for BPH, we can simply hold off the Tamsulosin during the 5-day course of the Paxlovid treatment. And same as the statins. Tina, you can click one more time. So the statins, everybody's on statins, and we'll ask the patient to hold off statins for 5 days as well during the Paxlovid treatment. And for amiodarone, it gets a little tricky because we either need to reduce the dose by 50% or hold amiodarone Since the half-life of Omicron is very long, like 48 days, and we also recommend to talk to the cardiology for the patient. And for HIV patients, it's okay to take Paxlovid on top of HIV medications, even if the patient is already on ritonavir or cobicistat. And for anticoagulants or antiplatelet agents, it again gets a little tricky, depends on the dose and indications. Just remember, Paxlovid is contraindicated with rivaroxaban and also ticagrelor. And if the patient is on warfarin, and we also need to monitor INR very closely as well. Next slide. And my hospital also have a large transplant patient population. So the Paxlovid has drug interaction with some of the immunosuppressants such as tacrolimus, cyclosporins, and sirolimus. And the American Society of Transplantation recommended not to use Paxlovid in solid organ transplant patients because the drug-drug interaction is very difficult to monitor in the outpatient setting. And lastly, we also need to watch out for cytochrome P450 inducers, such as some of the anticonvulsant, rifampin, herbal supplement, because they can reduce Paxlovid level significantly. So Paxlovid is contraindicated for with the strong inducers. I don't expect everyone to remember all the drug interactions. So there's a very great website you can use to check COVID-19 medication drug interaction. It's called the Liverpool Drug Interaction Checker, and it's free, and it's recommended by the guidelines. And the website can be very helpful. You just need to type in the drug name. It will tell you whether to use together or don't use together with Paxlovid. And in my hospital, our computer system also will alert clinicians if there's any drug medication which can be contraindicated to Paxlovid and which can be very helpful to our physicians as well. Next slide. So now I'm going to go over some of the adverse drug reaction. I have to say all these medications are very well tolerated. For Paxlovid, most common reaction reported from clinical trial is dysgeusia. It's close to 6%, which is dysgeusia means a changing of taste. So I have patients report that to me that they have metallic taste or bitter taste in the mouth, and it's very persistent with peaking 2 hours after each dose and subsiding somewhat about 7 to 8 hours into each dosing interval. So some patients also have diarrhea. And I always tell the patient that, good, you're staying home because you have COVID-19, you're not going anywhere, so you can manage the diarrhea. And most reaction goes away once the treatment is completed. For baptilovimab, like any other monoclonal antibodies, patient can have infusion-related reaction, but it's very rare. So far, I had one patient told me that she felt flushed when she get the IV push, but it went away very quickly. But we do not routinely pre-medicate a patient before we give monoclonal antibody, since the reaction is not very common. But for patient with extensive history of allergy, sometimes we do pre-medicate a patient with cetirizine, Zyrtec, that's a brand name. Baptilovimab also has advantage of that the administration is over IV push, just over 30 seconds, which is quick. But all the other monoclonal antibody infusions usually from 20 to 30 minutes. And when we have patients have some reaction, sometimes we can slow down the infusion to 1 hour if needed. And for molnupiravir, which is we don't really use very frequently, the common adverse drug reaction is diarrhea, nausea, dizziness, which are reported during a clinical trial. But again, overall, these medications are very, very well tolerated. Next slide. So FDA quickly approved these medications as emergency use authorization. What about drug distribution? In other words, do we have enough medication for everyone? So in the US, the federal government signed contract to purchase millions doses of medications from the pharmaceutical companies, but the federal government will give the drug to the state, and the state Department of Health decide how much medication to give to each hospital based on the number of COVID-19 cases to ensure equity. So if there's high cases of COVID-19 in your hospital area, then you will receive more medication. And if there's less cases of COVID-19, then you receive less medication. So the supply can be fluctuating. So we need to be smart about how to use these medications. Even though FDA has a set of emergency use authorization criteria on who to give it to, but from time to time, we need to make our own criteria to become even more stricter since we don't have enough medication to treat everyone. So our priority patients are immunocompromised patients, such as solid organ transplant, bone marrow transplant, oncology patients who are on active chemos, elderly patient who's older than 65 and not fully vaccinated. These are our target patient. Next slide. So we do have a command center, which is run by us, leading by the antimicrobial stewardship team. And all the requests for monoclonal antibody or oral antivirals go through the covid@Montefiore.org email request. Then we will screen the patient and we'll get patient treated at our infusion center or our ED for monoclonal antibodies. And our providers can also prescribe oral antivirals as well. Although the monoclonal antibody or oral antivirals are approved for outpatient use only, but for inpatient, if the patient admitted for non-COVID related reasons, such as, for example, patient admitted for bone fracture or appendicitis, incidentally, we found this patient has positive COVID, we also treat those patients as well. Next slide. So this is our own, next slide again. Next slide. So this is our own institution data. And during the past 2 years, as of last week, we treated 2,913 patients between our emergency rooms and the infusion center for the monoclonal antibodies. And you can see from the graph here, since November 2020, New York City, we experienced the second and the third and the fourth waves of COVID-19. Next slide. And based on the circulating variants, and you can see we move from one monoclonal antibody to another monoclonal antibody, each monoclonal antibody represented by different color. And right now that we are dealing with Omicron B2 variant, so we are strictly using the bebtelovimab since late March, which is represented in the purple color. And next slide. And we also track of our patients in terms of admission rate post-infusion within 7 days of the treatment. So on average, our admission rate is about 4%, which is consistent with what we see in the clinical trial. And next slide. So here are the oral antiviral prescriptions processed through the hospital computer system. Definitely more Paxlovid being prescribed than molnupiravir. So I have to say that the usage is lower than what we expected, as clinicians are still learning the process and to familiarize with the drug-drug interactions of Paxlovid. And the New York State Department of Health just released that they will be implementing test to treat sites, which means that once patients tested positive at the site, and they will be sending the prescription of Paxlovid through designated pharmacy, so the patient can get treated immediately. And so this is all real data from our hospital. So during the past 3 weeks, you can see an increase of COVID-19 and increased Paxlovid use. So definitely COVID is not out of the woods yet for us in the US. Next slide. And this is Evusheld, the Texagevimab and Silgavimab. So this is for pre-exposure prophylaxis, as Dr. Vijaya just mentioned earlier during her presentation. And recently, the FDA increased the dose of Evusheld to provide better coverage for Omicron B2 variant. And we also have a tier system in place to prioritize patients to receive pre-exposure prophylaxis. And the New York State Department of Health initially thought that everyone would like this drug, but in reality, the uptake for this medication is very slow, a lot slower than we would expected. And I think some of the reason can be for the slow uptake is due to increased vaccination effort, because vaccination is a higher priority than the Evusheld. So we really want a patient to get fully vaccinated, including the 4th dose for our immunocompromised patients before we give Evusheld. Next slide. So let's move on to the 4th dose of vaccination. Do we really need a 4th dose? Next slide. So there's a study done by Levin and his colleague. They conducted an open-label, non-randomized clinical study of immunogenicity and safety of the 4th dose of either Pfizer or Moderna vaccine to be administered 4 months after the 3rd dose. So after the 4th dose, both of the mRNA vaccines induced IgG antibodies against the SARS-CoV-2 receptor binding domain and increased the neutralizing antibody titers. The titers were slightly higher than those achieved after the 3rd dose, and both vaccines induced an increase in live neutralization of Omicron variant and other viral strains, while the antibody levels in the control group continued to wane. The study also found that the 4th dose did not lead to substantial adverse events other than just the usual mild systemic or local symptoms in the majority of the recipients. So the study concluded that for the 4th dose of mRNA vaccines, it's immunogenic and it's safe and somewhat efficacious, primarily against the symptomatic disease. And the maximal immunogenicity of mRNA vaccines is achieved after the 3rd doses, but when you give a 4th dose, the antibody titer can be restored. Next slide. So here is the CDC recommendation in regarding to the 4th dose. So for patient who's older than 18 years of age with mild to moderate immunocompromised conditions, so the 4th dose is recommended if the 3rd dose was about more than 3 months ago. And for patient who's older than 50 years old, and if patient received the 2nd booster, which is kind of like the 3rd dose, at least 4 months before the first, the 2nd booster will be the 4th dose, at least 4 months from the 1st booster, kind of like the 3rd dose, it's recommended for the 4th dose. And also the mix and match is also acceptable as well. Next slide. So speaking of mix and match, this slide was presented during the advisory committee on immunization practice by the NIH on the heterologous platform boost study on mix and match Pfizer, Moderna, and Johnson & Johnson COVID-19 vaccine. So the study shows that the heterologous boosts, which is the mixed vaccines, can trigger similar or higher serologic response compared to the respective homologous booster vaccine, which is the matched vaccine. So the mRNA vaccine resulted a higher antibody titer during the first 28 days after the boost. And there's also no safety concerns identified during this study. So in general, we encourage everyone, especially the immunocompromised patient, to get the 4th dose of vaccine. And also mix match is okay for booster in the US. So here's my references. And now we are open for question, and I'm going to turn the floor back to Dr. Huang.
Dr. Gao, thanks so much for your excellent talk. So we are all open. Is there any question from the panelists? How about Dr. Yang?
Yes, I have one question for Yi. Because a special group like the pregnant fit patient, do you think the remdesivir or Paxlovid, which one is more safe for this kind of patient?
Paxlovid is safe for the pregnant patient. We've offered Paxlovid and a monoclonal antibody for pregnant patients. And recently we published some of the data that we treated monoclonal antibody for the pregnant patient. I have to say the outcome is pretty promising. And the Paxlovid is kind of like newer kid on the block. And for our pregnant patient, we started offering Paxlovid as well. Other than the bitter taste, metallic taste in the mouth, and most patients tolerate very well. And usually when we treat pregnant patients, we also want the patient to discuss with their own OBGYN doctor as well and make sure they're on the same page with us. Usually if the patient agrees and the OBGYN doctor also agrees, we will treat the patient. But just remember the treatment window for Paxlovid is 5 days. Once the patient passed 5 days, then we won't be able to offer Paxlovid. Then we will change into the monoclonal antibodies. And for remdesivir, it's also safe during a pregnancy. The clinical trial excluded pregnant patients, but after remdesivir was approved by FDA, we do treat a lot of pregnant patients with remdesivir as well. The reason we did not offer remdesivir for outpatient in New York is because we have issue with insurance coverage. Because based on the FDA approved indication is for inpatient treatment only. And then when the Pine Tree study published, and there's a lot of push for outpatient use, but the logistic-wise, the infrastructure of the healthcare system is that if we offer the treatment for the patient gonna stuck with a huge bill. It's extremely expensive for the treatment. So until the insurance cover the treatment, I think the Medicaid, Medicare already cover, then we can offer the treatment. Another obstacle we encounter for offering remdesivir as outpatient treatment is that the duration is 3 days. So that means the patient will come to the hospital or designated location to get treatment every day for 3 days. And we also worrying about infection control. And we want to quarantine these patients, but now we ask them to come to the hospital, get treated. So in New York, we offer Paxlovid first, and then the monoclonal antibodies. And we still reserve the remdesivir for mainly inpatient use. And based on the Pine Tree study, we do offer 3-day treatment, even if the patient is in the hospital, if they have mild or moderate symptoms.
Thank you so much.
Dr. Guo and Dr. Vijayan, and I just want to stress that the use of these oral management is really specific for targeted population, right? It's for people who are immune suppressed and who have no response to their vaccination. It's not something that just giving to everyone who has COVID. Is that correct?
Yeah, it's an area of a lot of debate, Dr. Chen. So yes, we would absolutely not recommend it for anybody that was completely healthy and vaccinated. There's the population that is vaccinated but has traditional high risk factors such as hypertension or cardiovascular disease or lung disease, who should respond to the vaccine, and their risk of hospitalization is very low. But that population, we are still offering it. Now, whether they truly benefit, I think, is an area of debate. But at least for now, because we have supply, we're offering it to all individuals who would have previously been considered high risk by traditional factors. And pregnancy is one of those factors, so it is actually quite important to treat our pregnant women. Just to add to Dr. Guo's comment, we've had a lot of experience with ritonavir in our HIV positive population. So we actually have very little hesitation giving Paxlovid to the pregnant women. We do actually require consultation with our OBs as well, as Dr. Guo had mentioned, but they're very supportive of this drug.
Thank you, Tara. How about Dr. Gu? Do you have any question about today's talk?
Same as just what Dr. Vijay just mentioned. Depends on the supply, drug supply, how much drug we're able to receive from the government. If we receive more, we can treat more patients. We can loosen up the criteria, including more the usual comorbid condition, diabetes, hypertension, interstitial lung disease. If we have less quantity, then we're going to be stricter. Then we will prioritizing the more immunocompromised patients first. Or sometimes we look at the number of risk factors. We need to have patient meet 2 or more risk factors. So we changes the criteria get stricter, loosen based on the quantity of medication that we receive. So we always keep eye out on how much medication we receive, and it takes up a lot of time to manage these, keep the service running, to keep everyone happy and then treat the patient appropriately.
There's a question about anticoagulation in patients with COVID. So Tara, I think you guys were part of Active One as well. So there are randomized controlled study on both moderate COVID as well as severe COVID. So in the group of patients who have moderate disease, meaning they're on low flow oxygen, they're more likely to have hypercoagulability. We've seen people with PE, DVTs, as well as portal vein thrombosis in this population. In the randomized controlled trial, there is survival benefit for full dose anticoagulation in the moderate patient. But when they progress into severe disease on high flow, on mechanical ventilation, the benefit from anticoagulation actually goes away. There's no difference between full dose anticoagulation and prophylaxis in a severe patient. Surprisingly, on the studies, there really wasn't a difference in bleeding risk for full dose anticoagulation. So in the ICU, when I have a patient who originally was on full dose anticoagulation for their moderate disease, but they progress to severe and come to me, I oftentimes would stop their full dose anticoagulation and switch them to prophylaxis, unless there's evidence of DVT, PE, or any other thromboembolic events. I'm not a pediatrician, so I can't answer any question about kids. Dr. Guo, do you have any experience? Do you know anything about the pediatric experience with ICU and encephalitis and the multiple inflammatory syndrome?
Because recently there's a baby 2 years old just died from the COVID-19 in Taiwan. So many experts or Taiwan is very focused on the kids suffer from the COVID-19. Dr. Guo, please.
I think the medication treatment for COVID-19 for pediatric patients is very limited. As you can see, most of like the oral medication approved for patients are older than 12 years old. And under 12 years old, mainly the treatment is still going to be remdesivir. So these are the treatment that we offer for the for patient who's younger than 12 years old. We did treat a lot of patients between 12 to 17, 18 years old with the monoclonal antibody and Paxlovid. But in the inpatient setting, the medication mainly be used for a pediatric patient will be remdesivir.
One more question from the floor, because some of doctors want to ask about the nutrition support for the COVID-19 critical care patient. Do you have any suggestion for the special nutrition support for this COVID-19 critical patient? How about Tina?
So the question is there any special nutrition needs?
Nutrition support,
Yeah, I think there is increased caloric intake, caloric expenditure. So our nutritionist does give them a little more, because we're treating these patients as if they have sepsis and septic shock. So the same amount of nutrition that we would give someone with any other sepsis will be dosed for these patients. So nothing special per se, but really the same way we take care of our patients with sepsis and septic shock.
Thank you. So is there any other question from the panelists? One more question. How about Dr. Gu or Dr. Lee? I think everybody get the right answer from 3 experts from America. So I think it's your working time. So thanks so much for your expert from the American and from the UCLA and the Montefiore Medical Center. Today we have a wonderful night for the learn from the American experience of COVID-19. So maybe in the next 2 or 3 months is a very tough time for the Taiwanese. So we have to work hard for this kind of so many patients. And we hope so see you very soon in the future. Thanks all the audience to joining today's session. Thanks so much. See you very soon. Bye-bye.
Thank you for the opportunity.
Thank you.
Bye-bye.
Bye.
Thank you.
Have a nice day.
Bye-bye. Thank you.